Dear colleagues, good morning. It gives me my great pleasure to present the results from the biobehavioral survey we conducted among MSM population living in Skopje during the late 2013 and beginning on 2014. And I was fortunate enough to do this project as being one of the first fellow of MediPIET. So just brief background information. We already know Macedonia is a small Balkan country with the population of 17,000 million people, with the capital city of Skopje, host of this annual scientific conference. The population in Skopje is 617,000 people, while the males living in Skopje are a little bit less than half of, or 304,000 people. Well, speaking of men, we are getting to our population of interest, namely men who have sex with men. This population, unfortunately, more often than not, is exposed to social discrimination and stigma in Macedonia. And due to this stigmatization, this population remains hard to reach for regular preventive measures or also for distribution of information material, since there are no public places where MSM can gather, let's say, like public cafes, bars, etc. What's even more difficult is that we have only limited number of civil organizations working in the field of HIV prevention with this population. To be more exact, we have only one NGO working with this population on prevention of HIV. So, since MSM is recognized as one of the population with higher risk of HIV and STIs, they are under active surveillance here in Macedonia. In the last 8 years, we have conducted 2 biobehavioral surveys among this population, but we did not find any HIV positive cases. However, in 2007, we had a very small sample size of only 37 people, and the prevalence was 0. In 2010, we changed the sampling strategy and used respondent-driven sampling. We obtained 382 participants from whom the blood drawn was sampled, but still the prevalence weighted prevalence was 0, with the confidence interval from 0 to 0.2. In this same year, we did a population size estimation. This was the first population size estimation of MSM in Skopje, and the estimates was 5,470 MSM that lives in Skopje. Besides the active surveillance with biobehavioral survey, HIV is part of mandatory notifiable diseases in Macedonia, and here we see some interesting trend which is observed in the rest of the Europe. In the last 15 years, we had only 188 cases, cumulative number of newly registered HIV cases. But what's more interesting, you can see in this graph that in the last 4 years, we have almost exponential rise of number of registered cases, and most of them are due to MSM mode of transmission. Most particularly in 2014, 74% of all registered cases were due to MSM mode of transmission. Having in mind in this background data, we conducted a survey in order to assess the risk behaviors associated with HIV and STI transmission, and as well to estimate the HIV prevalence among MSM in Skopje, Republic of Macedonia. The study was designed as cross-sectional biobehavioral survey. It was implemented in a period of 3 months from December 2013 until February 2014. For the sampling, we used a respondent-driven sampling, which is the chain referral system where the respondents recruit by themselves. This is well-recognized system, and it's gaining popularity in last year for sampling hard-to-reach populations such as MSM in Skopje. It controls the biases with self-recruiting, but we can talk after this presentation. We estimated that we need 400 participants, and the estimation were done based on the prevalences we obtained from the previous survey. Inclusion criteria was that participant needs to be male, obviously, on age of 18 until 55 years, and to have had anal sex in the last 12 months. they need to be residents in Skopje, actually to live in Skopje for at least three months, so we can explore their social networks within the Skopje. The venue was Skopje, an administrative office very nearby the Institute of Public Health. Data collection was done, behavioral data was collected with face-to-face interview. The interviews were done with trained NGO staffs who are trained and work with this population. And we used structured questionnaire with 63 questions with blocks on sexual risk behaviors, knowledge and attitudes, risk behavior associated with injecting drug, with also for HIV testing and counseling we had a part. After successful completion of the questionnaire, each participant would give blood samples and receive pre-test, previously would receive pre-test counseling. All the results were analyzed in the Institute of Public Health. Biological samples were tested for HIV using ELISA for detection of HIV antibodies and P24 antigen, while immunoblood test was used to confirm any positive results. The data afterwards, behavioral and biological data, was put in special software called RDSAT, Respondent-Driven Sampling Analysis Software, which controls and weights all the results. Afterwards, this is the first wave of the recruitment. In the second wave, participants would receive their results and also receive the post-test counseling. Speaking of results, so this is the recruitment network, which is drawn from this survey, and it's done using the software called NetDraw. So here we can see that we have 6 initial recruits. Those are the bigger squares. The initial recruits are selected from the research team, and afterwards each of them recruits an additional 3 people. So the chains go, and the waves you can see go further into the network. So you can see from this side, these are color-coded. The red color represents the Roma nationality, and they are a little bit overrepresented in our sample, and the other colors you can see by yourself, Macedonian and Albanian. Those are 3 major nationalities included in this sample. Total number of participants in this survey was 426, including 6 initial recruitments. But as you can see, only 3 initial seats produced a network size of meaningful magnitude. The other 3 were very limited. Here I will present some key behavioral data as well as HIV prevalence. We analyzed the risk behaviors associated with HIV transmission, namely the condom use, and the condom use during the last sexual intercourse with male partner was 26.6%. A little bit higher percent, or 46.8% of the participants use condom with casual sexual partner during their last sexual intercourse. And also what's interesting in our sample that almost 64.9% of the participants had also female sexual partner in the last 12 months. In terms of commercial sex, 14% had paid for sexual services in the last 6 months, while they sold or exchanged services almost the exact percent, or 13.9%. Self-reported symptoms of sexually transmitted disease reported 15.3%, while only 90% reported to have done HIV test in past year. And the HIV prevalence was estimated to be 1.9%, with confidence interval ranging from 0.5% to 2.9%. We did some bivariate association in order to further explore the risk of HIV. However, due to relatively small number of HIV positive cases, our association were not significantly statistically significant for condom use or other well-known recognized risk behaviors. However, I decided to present some, we explored if the age is group could be possible explanation. So people who were older than 25 years had higher odds to be HIV positive, but that was not statistically significant. We would explain this because they were exposed to more sexual contacts, of course. What's interesting here is that the nationality turns out to be risk factor, or MSM from Macedonian nationality had almost 10 times higher odds to be HIV positive compared to all other nationalities. And the confidence interval is in range from 2.19 until 67. So it's big range, but it's still statistically significant. And having exclusively MSM or gay relationships and sexual contact is not a risk factor compared to bisexual relationships. What are the limitations of this study? First, as in any other study with hard-to-reach population, it's hard to have statistically representative sample because we don't have the sampling frame. On the other thing, this was done only in capital city of Skopje, so the extrapolation of data and generalization could lead to some mistakes. We had quite high proportion of participants from Roma nationality, which does not correspond with the socio-demographic characteristic of population in Skopje. And some of the answers could be socially desirable, like the condom use. Even the NGO who did the interviews are trained to obtain honest answers. Still, we can sometimes get socially desirable answers. In conclusion, HIV prevalence among MSM was highest compared to all other previous surveys. What could be possible explanation for this is low condom use with regular and casual sex partner, commercial sexual activities, 15% of them both sold and exchange and buy sexual services, and we have low testing rates below 20%. So now probably quite a big proportion of MSM are not aware of their HIV status, and they can therefore spread the infection. As every survey needs to be information for action, our recommendation was to introduce the HIV counseling testing within the NGO offices, because up till now it was only available in public health services or public health hospitals. Increase the number of free condoms and lubricants and information materials, increase the number of teams working with this group, and also expand the number of actual NGOs who work. And I'm glad actually to say that some of these recommendations are already implemented, like this year for the first time we introduced the HIV testing and counseling out of the health facilities within the NGO offices, and we increased the number of teams and lubricants in the field. So hopefully in the next round of survey we'll see the results. I would like to express that this study was financially supported by the Global Fund for Fights Against AIDS, Tuberculosis and Malaria. Our special thanks to the team of dedicated workers from NGO EGAL working with this population, and of course special thanks goes to laboratory staff from the Institute of Public Health, and last but not least, big thanks to all the participants in the survey. Thank you.
Thank you, Vladimir. Now we are open for questions. And is there any question, please?
Thank you. Mikic ECDC. Vladimir, very nice presentation, very clear.
Thank you.
Again, remarkably low rates, which is good news. A couple of questions. First of all, did you ask about other risk behaviors, so number of sexual partners or injecting drug use, and was that associated? And I know you had small numbers of HIV positive, but did those who you found to be HIV positive know of their HIV positivity? And if so, did you ask also about whether they were on antiretroviral therapy?
Thank you for your questions. Yes, we did analyze the other risk behaviors. For injecting drug use, it was very, very low, below 1% in this population, so it was not meaningful, of meaningful size. And in regard to the second question was that only two of 11 people who were HIV positive actually knew their status. The other one were newly registered. So this was indication that actually something is going on in this population and something new.
Thank you. Please.
Okay. I was also quite impressed both with the study at large, but also that you managed to reach out so well in the Roma population, because we know that this is a population that by itself is hard to reach. And then if you have the added complexity of being an MSM within a group that is already hard to reach. Do you have any suggestions why you managed? Was this NGO that you were relying on, did they have Roma working with them? Because we know also from other interventions that in order to reach out to Roma, you really need to have good contact with people within the Roma population, health mediators, etc.
Thank you. Yes, you're quite right. However, in Skopje, we have one large Roma settlement with almost 20,000 Roma living there. And this NGO working with the MSM has their offices in that municipality as well. So they have also Roma field workers working with this population. And one of the team members was also from Roma. And we started only with one Roma seat or initial recruit in that settlement. But it turns out they're quite well networked. So, and their response rate was higher than any other group. Probably due to also incentives, maybe that's also a factor. We try to lower the incentive as much as possible and to offer more tests to have valid results. But our problem was actually to include more other nationalities than Roma in this case. This was the same actually in the last survey as well. But we have very good field work with Roma, so that's why not explanation.
Thank you. Other questions?
Can you hear me? Yeah, my name is Ziad Al-Khatib from University of Balamand in Lebanon. Thank you very much for this, and I have a methodology question because I'm also facing it right now for MSM data. For the weighted sample that you have done in the bivariant analysis, was it weighted or unweighted?
Sorry, I was not clear about, but this is sample estimates. These are not weighted bivariate analysis.
Okay.
So it's simple, but at that time when we were doing this survey, we were still not sure about the weighted bivariate analysis coming from RDS. Now there is more literature, and of course we'll do that. But afterwards I did, and it comes pretty much the same. So the weighted odds ratio is 10 point something.
So regarding the weighted analysis, what would be the value added? Because this is something I'm struggling with my colleagues.
Mm-hmm.
What would be the value added if we cannot really, when we want to do data crunching later on, we have to do it the unweighted? I would love your help on this.
I mean, the added value of weighting the data would obviously be you'll have more statistical power and more precise, because if it's not weighted, and then comes to like snowball sampling, because the weights are the one who actually make this kind of survey more statistically, let's say, correct. Because at the end it's still not quite simple random sampling, so the weights contribute to the statistical significance.
Okay, thanks.
Welcome.
Thank you, please.
Thank you. Hello. Thank you, Vladimir, for a nice project. My question is about the risk for nationality of Macedonians. It appears to be a risk factor almost 10 times higher than other nationalities. I would like to ask you, do you have any hypothesis or suggestions or explanations for these results? Thank you.
Actually, this result was puzzling us a lot, and we tried to hypothesize what could be the possible explanation. One maybe is that circumcision could be a protective factor because because male Macedonians are mostly Orthodox religion, while the others, Roma and Albania, are mostly Muslim. And maybe this is the factor, maybe it's the viruses within this community, because if we can go back to the networks, we can see that, but again, Roma networks are fairly restricted only between themselves, where the Macedonian, there is some interaction with other networks. So I cannot find concrete answers, so probably we will need to go further in the next survey. But this is really something we need to look in next survey.
Thank you. Please, other questions? Please.
Thank you, Vladimir, for your presentation. I have a question about the consent of blood sample and how they react because they are stigmate. And it was easy for you to make this? Thank you.
Okay. Thank you. As you can see in the previous rounds of survey in 2007, the blood sample was not part of eligibility criteria. Here they were asked if they want to participate, they needed both to complete a biological and behavioral part. And we printed the invitation cards, which they give between each other. And there is clearly stated that they need to give a blood sample. So only the ones who are willing to give blood sample will come to the site. So this made the things easier. Thank you.
Thank you. Is there any question?
Okay, so the very last question.
Thank you, Vladimir, for this really lovely presentation. I'm just curious, do you know the difference in the frequency of anal sexual intercourse between the Macedonians and the Roma population? Because I usually suspect that maybe Roma population could perform much more commercial sexual.
Yes.
And in fact, it's a little bit confusing for me that the HIV prevalence is higher among the Macedonian than the Roma.
Yes. I'll go to one of, let's say, my backup slides. Yeah, it's really puzzling results, because one would expect that Roma population engage in more risk behaviors and they should have higher HIV prevalence. However, we find the opposite results. We didn't find any significant difference between condom use between Macedonian and other nationalities, so this was not a factor. What was also more puzzling is that hepatitis B was higher in Roma nationality compared to any other. So odds of being hepatitis B was 3 times higher in Roma compared to other nationalities. So they engage in risk behavior as well. So probably the virus is still not introduced in this community, maybe. Yeah.
Thank you, Vladimir, for very interesting presentation.
Thank you.